Hi, everyone. Welcome to the Cleft Palate Craniofacial Journals podcast, which is video and audio. And I'm really happy to be the host. I'm Pat Chibbaro, PEDS nurse practitioner in New York. And I was really happy to see this paper that I definitely wanted to podcast because it brought back memories for me from way back when being in the NICU and trying to figure out as a team when to and how to safely extubate kids who have had mandibular distraction. So let me tell you about this paper. And you can find it OnlineFirst, September 24th. So when you go onto the journal, you click on OnlineFirst and go down, go to page 2, and then you'll see this paper. And the paper is What Factors Affect Safe Bedside Extubation After Mandibular Distraction, and the authors, and they're from the Department of Plastic and Oral Surgery and the Department of Anesthesia at Boston Children's Hospital. And they are Dr. Cory Resnick, Dr. Andrew Deek, Ryan Caprio, Snigdha Jindal, Faye Evans, and Raymond Park. And I'm really happy to have Dr. Resnick on to talk with me about the paper. Cory, thanks so much for joining me.
Thanks so much for having me, Pat. It's a real pleasure to be here, and it's really exciting to be able to discuss this, particularly with you, since you were there for the very nascent days of mandibular distraction.
Yeah, it's so the first distraction that we did with Dr. McCarthy was in 1989, and so that patient was not in the NICU, but shortly after we started to really look at doing this as early as possible. Obviously, to either prevent a trach or to prevent one, or maybe to try to get one out. But I'd love to ask you, which is usually the first thing I always ask the authors, is why did you and your team want to take a look at this particular issue? What motivated you guys?
Well, since the era of mandibular distraction started back at NYU, it's come a really long way. Now it's become really the primary first-line surgical treatment for infants with Robin sequence, at least in the United States. And we've been able to work with it to the point where it's fairly predictable and we can understand what to expect from it. So now we're starting to hone in on some of the finer details of how to improve the process and just identify which patients are going to have which types of processes and outcomes. And so this investigation is part of that endeavor to try to determine really what the best extubation protocol should be for infants that have undergone this procedure, so that we can make sure that our babies are safe and that we're not having opportunities for really difficult outcomes to occur, but also not expending unnecessary resources when they don't need them. That's really the era that we're in right now. And that's what this was about, because in our hospital in Boston, we had for a long time a process where we would maintain intubation for 3 days after a routine mandibular distraction operation, and then return to the operating room for the extubation process. Which would typically go very smoothly, but is difficult logistically to arrange to go back to the operating room, and the resources involved in that are a lot. And we have a wonderful intensive care unit team that's very capable of managing their needs. So the question was always, well, should we just do this extubation in the intensive care unit in the neonatal ICU? And it was hard to make that transition without some data to suggest that that's really safe, because even though it probably is safe, we just don't want to make an error there.
So maybe before we talk a little bit about maybe some of the challenges or things you didn't expect to find or did expect to find, maybe just give us a little overview of your paper. But everyone who's listening or watching, you need to read the entire paper. You need to read that paper.
Thanks. Yeah, so this was a retrospective investigation. We had 52 patients. Importantly, about a third of those patients had known genetic syndromes, and almost half of those patients had comorbidities, even if they weren't known genetic syndromes. And we went through the typical protocol that we use, which is approximately 3 days of post-operative intubation after routine mandibular distraction. All these patients were less than 6 months of age when they had their distraction procedure. And then they would spend 3 days intubated in the neonatal ICU. And many of them, though not all of them, because our protocols were for extubation were not as as clearly pathway driven as the rest of the procedure. I made pathways for the mandibular distraction procedure itself, but the extubation was a little bit up to the team.
Right.
But most of them would go back to the operating room for extubation. Some of them were extubated in the ICU. And we looked retrospectively to see how many of those patients needed reintubation. That was the primary outcome. And only one patient actually required reintubation in our study. And then, more granularly, were there factors that we could identify that led to any airway problems after extubation, even if it didn't go all the way to reintubation? Did they need some supplemental oxygen? Did they need CPAP? Did they need non-rebreathers? Were there some semi-emergent type of situations that would have better been handled in an operating room setting versus an ICU setting? And if there were any patient factors or health factors related to the process or the patient that could have predicted those.
So when I read the paper, one of the things I was thinking about was taking what you've seen and then thinking about how or if you can actually develop a protocol that teams around the country could use. And I guess one of the things I was thinking was, and I think in the paper you distracted 2 millimeters a day. Is that right?
That's right.
And I remember when we first started doing this in the NICU or the PICU, it would be, I think it was 1 millimeter a day. And so I guess the question is, and I've been out of it a little bit since I retired a few years ago, but is it pretty much is the same type of protocol for activating? Do they start right away? Do most teams start right away? Is there a delay? And does that, do you think, affect what the protocol for extubation would be? I guess I'm trying to think, what are the sort of the obstacles to actually having a protocol that teams around the country could look at, could be, something that is really applicable to all teams, to all kids?
Yeah, that's a great question. And, as you've said, everyone has a different protocol for this, and there's really no universal buy-in on how to do this properly. My protocol has been for the last decade plus to have 2 millimeters of advancement per day, starting on postoperative day 1. I don't use a latency period. I split it into 1 turn in the morning, which is 1 millimeter, and 1 in the evening, and continue it until the lower ridge of the alveolus is about 2 to 4 millimeters in front of the upper ridge. And for me, on average, that's about 20 to 24 millimeters of advancement. Because I have a very horizontal vector, others will say that you need more like 30 or 35 millimeters of advancement, although often that's relating to some more vertical orientation of the vector, so it's not as far forward. So I don't know there's a magic number, but it really has to do with just how much the mandible is advancing and bringing the tongue base away from the airway. Would changing or universalizing, so to speak, that protocol bleed into a change in the anesthetic and intubation related management is a great question. I suspect not very much. My feeling has always been that in patients that don't require preoperative intubation, now some of these kids, of course, will maybe have trachs or will be intubated preoperatively because their airway is so tenuous. So that's a slightly different scenario. But in patients, and that was an exclusion criteria for this study, so none of these patients were preoperatively intubated and none of them had trachs. So in this type of patient population who didn't need to be intubated before the operation, I don't see why they would need to be intubated after the operation. The only thing that has changed, besides the process of hopefully improving their airway even further, is the trauma of the intubation process that occurs in the operating room. So that's where my protocol of 3 days came around, because we've observed that fluid shifts and swelling associated with airway trauma from the intubation process itself should usually resolve by around 3 days. And we also do use a protocol to have a negative fluid balance, use some steroid taper to prepare us for that 3-day mark, to try to decrease swelling as much as possible. But really all I think we need is to get them back to their preoperative baseline, because they didn't need a breathing tube before the operation. So why should they need it now? So I don't know that, some will suggest that we should maintain intubation until the mandible is in a position where the airway is much better. But I don't see why that would be necessary, because again, they didn't need to breathing
Right.
tube before, when the mandible was in its home position. So why would they need it after? So I really think that we can probably extubate these kids after a reasonable period for fluid shift and swelling to go away pretty safely.
So I often ask this question for anyone that's conducting research. Couple of things. One, was there anything that you found that you didn't expect, or pretty much it was as you hypothesized?
I would say it pretty much was as hypothesized, but it really did put a fine point on a few things that I have clinically suspected and seen, but never had real data to show. Particularly that certain comorbidities are really the driver of what the airway situation is going to be. I think we all inherently know that,
Mhm.
but it's hard to put that in numbers. And I think that's where some protocols really might come from, is that it was clear from this study, as well as we've all seen from clinical observation, that kids without comorbidities and without syndromes that have micrognathia, typically with a cleft palate, probably a protective effect of the cleft palate, although I can't absolutely say that from data, and have a successful mandibular distraction process, are probably going to do really well. And
Right.
they probably don't need tremendous resources like a return trip to the operating room for extubation. They probably can be extubated safely in the intensive care unit. And I think that this where to extubate question is really just sort of one surrogate marker for their outcomes. I think other questions that we would ask about how they would do will also be that they will have a favorable outcome. And kids that have certain syndromes, not all syndromes, so Stickler syndrome actually was found to be a little bit relevant in
Right.
this study, but I would say by and large, kids with Stickler syndrome do really well.
Mhm.
But certain syndromes and certainly comorbidities, particularly cardiac and pulmonary comorbidities, are probably going to be a lot more tenuous. And so I think we need to have protocols that address the actual patient population rather than just the operation. I don't think we can blanket say
Mhm.
every kid that has mandibular distraction needs this protocol, but rather kids with cardiac disease, kids with pulmonary disease, and certain syndromic diagnoses probably should follow this type of pathway, and other kids should follow a different pathway.
Right. So the other question, what about challenges? What was challenging? I think people that are listening or watching or thinking about embarking on research often want to know, what am I up against when I do this type of study?
Yeah, I think in general, from the study design perspective, the biggest challenge I think is to pick the best outcome measure, because it's tricky for this. We chose as our primary outcome measure the rate of reintubation. But that's a pretty binary thing. Either you're reintubated or you're not.
Right.
And that doesn't really tell the whole story. So even though that was our primary outcome measure, we had a series of secondary outcome measures that we also looked at that tried to speak to what was really going on with their airway management, and how difficult was this? Are we having, semi-emergencies in the
Mhm.
ICU where there's a lot of angst about this patient? They may not get to the phase of being intubated, so they'd still be a no
Right.
on reintubation, but
Mhm.
it's making everybody really nervous. Or is this a smooth process? And I think picking outcome measures that really speak to the story you're trying to tell is the hardest thing to do really well. And then specifically in the Robin sequence space, I think dealing with the extreme heterogeneity of the population is the biggest challenge. I think forever we've made some artificial buckets of patients like syndromic or non-syndromic or PRS plus or other things like that,
Right.
and they're just not really sufficient to stratify these patients properly. I mean, a patient with Stickler syndrome or a patient with Treacher-Collins syndrome are both syndromic, but they're nowhere near each other in what we
Right.
expect. So I think really sorting through the heterogeneity of this patient population, and having that not color the outcomes but rather inform the outcomes is really a hard thing to do in study design for this type of project.
So, how do you think this is, or has been received by those who do what you do? How might it be impacting, your field? So, as a surgeon.
I hope that people will read this and see what the real spirit of it is, even behind just the very specific outcome measures. In order to do this research study, of course, we have to have a specific research question, a specific series of outcome measures. But I think that this can tell a bigger story than that. So, some might say, well, gee, in our hospital, we never go to the OR for extubation anyway. We do it in the ICU. That's always been the protocol, and therefore this doesn't help us because that's the premise, is that you might go to the OR. And I would say, well, that's not, yes, that was part of the question, but that's not really the spirit of this. Really, the question we're asking is, are there certain patient factors that can inform how this process will go, no matter what the location of it is? And so, I think that we can all, even if our protocols don't match up with exactly what I do and what I described here, I think we can all learn from this that there are certain factors about our patients that we should take into consideration as we manage them.
And you know what I was thinking, when I started, there was no internet. There wasn't a place for parents to go and research and check every paper. And as you know now, they are coming in, challenging you with the papers that they're reading. And so when I see your paper, I think it's actually a good thing for a parent to know, okay, this is the reason why we here are going with this protocol. And I think this is also important. I think it not only impacts those who are doing the work, but also the parents. I think for them, they're much more savvy. They're reading these papers. And I think if I were a parent, I was reading your study, and my son or daughter was your patient, and this is something that you decided to do, for them to know that it's been studied and there's data on it, I think is also important. So I wonder what you think about the impact of social media and the internet, and parents now having access to this, and how has that impacted your relationship with them?
Yeah, that's a great point. And I think that's really important. I think that, as we've gotten better at these techniques, we start to sometimes take for granted the power of these operations and the benefits that they can have. But there's always work to be done. We can always do a better job in the management process. And I think we are learning, in modern times now, that there's so much more to the family experience and the patient's experience than just whether this operation is going to work or not.
Right.
How the management process goes, how the family is informed, how each step of the process is described and discussed to them, how much data is behind what we're doing, and how much is based in real science rather than just our conjecture. The parents are attuned to all of these things.
Definitely.
And they should be. They're an informed consumer now,
Mhm.
in a way that they weren't decades ago. And so it's important for us to keep up with that and always try to do better. Even in an operation that I won't say we've solved this problem or figured it
Right.
out, but it's come a long way since 1989. And now
Absolutely.
it's done in many places very successfully, but that doesn't mean the work is done.
Absolutely. But I look at this paper and I think, this is the kind of paper I would refer a family to if they were doubting what you were recommending to them about when to extubate, if, how, where to extubate your child. So I think, papers like this they really are important, again, not just for your colleagues, but for the parents. Because as the nurse practitioner, I'm always looking at, the whole picture, and, what the more that we can inform the parents, I think that they feel like they have a little bit more control, because and more confidence in what you're recommending. So I was really glad to see that. I have one other question for you before we wrap up. And it's, there are a lot of med students and residents who are probably, hopefully, looking at this and wonder, what advice do you have for them when they're starting to embark on doing research?
I think it's just really about being curious and always asking questions about how we can be better. Not to be, lulled into this sense that we're already doing the best we possibly can. Even in things that we think we've figured out, there are always components that we don't understand well enough, or ways that we could improve the process, even if it's not just in the surgical outcome, but might just be in the family experience or in other places. There are always ways we can improve our skills and our process. And so always have that question in your head of what can I do better? And that is really what informs all of my research. Is I just come up with ideas about how maybe something could be done better than we're doing it now, and just try to test that theory.
Right, right. Well, I was really glad to see the paper, and it brought back, a lot of memories for me. So let me read this paper again so that you can all go and read the entire paper. It is something that you can find on the journal OnlineFirst from September 24th. It is What Factors Affect Safe Bedside Extubation After Mandibular Distraction. And this is the work of the team in the Department of Plastic, Oral Surgery, and Anesthesia at Boston Children's Hospital, Dr. Cory Resnick, Dr. Andrew Deek, Ryan Caprio, Snigdha Jindal, Faye Evans, and Dr. Raymond Park. And Cory, I'm just so grateful that you took the time to speak with me about this paper, and I hope to see you at next year's ACPA meeting is in Boston.
Indeed.
So yay
Coming to
for
my
that.
town.
So yay for that. So thanks again for joining me for this podcast. Really appreciate it.
Very good. Thanks so much, Pat. Appreciate it.